Sorry for the delay. Today, my lecture is on valvular heart disease, and the most important thing is the um heart valve disease occur when your heart valves do not work the way they should. There are you all of you know that there are four heart valves, and make sure that the blood always flows freely in the forward direction, and there is no backward directions. These are the heart valves which are shown in the picture. This is the aortic valve, this is the mitral valve, pulmonic valve, and the tricuspid valve. This is another diagram showing you the pulmonic valve, mitral valve, aortic valve, and the tricuspid valve. So there are two types of the pathologies which can occur with the valves. One is the valve stenosis, and another is the valve regurgitation. So valve stenosis or the valve regurgitations, and these are the valvular heart disease which are commonly seen in patients, which are named as mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitations. Today our topic is on the mitral valve. The most common pathology which you will see in the wards or in the OPDs in cardiology is the mitral stenosis. Uh, and the etiology almost always rheumatic in origin. Usually, the rheumatic fever is very common in our society. So most of the time, the mitral stenosis almost always in our society is rheumatic in origin. But in Western society, this is the normal valve, and from the upward, you can see this is the orifices of the mitral valve. And when it becomes stenose, it leads to very small slit. Other causes are sometimes the congenital causes, calcification. They can also lead to mitral stenosis. So this is the mitral valve, and the cause can be congenital. um and this is the pathophysiology. So the mitral valve is here. This is the left atrium, left ventricle, and this is the aorta. And you see here is the aortic valve. Here is the mitral valve. Here is the pulmonary veins, and um, and this is the right side. Normal mitral valve orifice is 5 centimeter square in diastole and may be reduced to 1 centimeter squares in severe MS. So the blood flow comes from the body to the right side of the chamber, goes to the lungs, and then from after purification, they come to the left side, and from the LA, the blood come to the LV, and then it goes to the aorta. This is the pathophysiology. When the valves becomes tightened, mostly there is reduced flow from the left atrium to the left ventricle. Further, as the stenosis or the narrowing increases, what happens is that the upper chamber, that the left atrium become enlarged, and there is a reduced flow into the left ventricle. And further, what happens is that there is the blood back up into the pulmonary veins. Behind the left atrium is the pulmonary veins, so the blood start to pool up in the lungs. And then further, uh, blood uh, when there is a chronic MS, the right side of the chambers are also becomes enlarged, and it leads to pulmonary hypertension. Further, uh, you can see pulmonary hypertension is the final sequence of the mitral stenosis. So this is the highlight of the narrowing of the mitral valve. When there is a narrowing of the mitral valve, that is mitral stenosis, there will be increased left atrial pressure, increased pulmonary pressure, pulmonary congestion. When there is pulmonary congestion, all the fluid is inside the lungs, which can lead to dyspnea, fatigue, orthopnea. And um, on the on this side, you can see that decreased blood flow to the left ventricle, decreased cardiac output, left ventricular, and this is all thing. So these are the clinical features. Most common features are the breathlessness and cough. Breathlessness is because the lungs is flooded with fluid, so this is leads to pulmonary congestion. Chest pain, this occurs because of pulmonary hypertension, because when there's a right ventricular enlargement, there will be ischemia, and that can lead to chest pain. Sometimes the patients with mitral stenosis also presented with hemoptysis, that is the blood in the sputum, that is due to pulmonary congestion or hypertension. Fatigue and palpitation, sometimes because of the enlarged left atrium, there is the blood stasis, there is the formation of clots which can dislodge and can give rise to stroke or other thromboembolic complications. So patients with mitral stenosis can present with these symptoms. Uh, then clinical features, patients can present with signs of atrial fibrillation, mitral fasces. If there is a fair colored skin, then you can see the flushing. Here you can see this female patient's cheek. There is a flushing of the cheeks that occur from cutaneous vasodilatations in the setting of severe mitral valve stenosis. On auscultation, uh, the time is short, we cannot go into the details, but if you have taken my first lecture, I told you what is the cause of the loud first heart sound in mitral stenosis, because the LA and इधर आना यार, ये बंद हो गया, ये आना बंद हो गया अभी, टाइम खत्म हो रहा है, आप लोग पता नहीं क्या कर रहे हैं. हेलो.
हेलो जी जी, आवाज आ रही है आपकी, स्टार्ट करते हैं आप.
हाँ, ये पैथोफिजियोलॉजी पे हम पहुंचे थे ना, ठीक है. These are the clinical features of mitral stenosis. So on auscultation, very important to look for the loud first heart sound and opening snaps, and this is created by the forceful opening of the mitral valve. There is also a mid diastolic murmur at the apex, and on auscultation of the lungs there are crepitations, pulmonary edema, effusions. You may find out RV heave and loud P2, which is secondary to pulmonary hypertension. So these things which you will learn when you come to the ward, because these are all the clinical findings. But for your convenience, you should know that first heart sound should be loud. There is an opening snap, mid diastolic rumbling murmur at the apex, and there is loud P2 and RV heave if there is pulmonary hypertension. On the examination of lungs, there are crepitations, pulmonary edema, and effusions. Then on the ECG, you can find out the signs of right ventricular hypertrophy and also atrial fibrillation. In chest X-ray, in mitral stenosis, there will be enlarged LA appendage, signs of pulmonary venous congestion. Echo is a very important investigation. So whenever you want to confirm the diagnosis of mitral stenosis, you have to do a transthoracic echo. This is the most important modality to see that the mitral valves are thickened, immobile, there is reduced valve area, LA is enlarged, and the Doppler is also very important when you go to your final year. The important thing is that when the patient came to you with MS with shortness of breath, and palpitations, you have to give them rate reducing agents like beta blockers or calcium blockers to control the ventricular rates, diuretics, which increase the release of water from the in the form of urine to decrease the pulmonary congestion. And if the patient is in atrial fibrillation, you have to use the anticoagulant. These are something which are advanced at your level, but you should know that we can use the balloon to open the mitral valve, which is known as mitral balloon valvuloplasty. Sometime you can, if the patient's valve is highly calcified, you have to go for the valve replacement. This is the method they are showing for balloon mitral valvuloplasty. The balloon is passed from the veins, right atrium, they puncture the atrium through the left atrium, and then at the mitral valve they inflate the balloon, and this is known as balloon valvuloplasty. Now we come to the mitral regurgitation quickly. Is the form where is the leakage of the mitral? The blood goes from the LV to the LA. In this with pathology, again the most common cause is the rheumatic disease, is the principal cause. In Pakistan also, rheumatic heart disease is the most common cause of mitral stenosis as well as mitral regurgitations. Mitral valve prolapse is another cause, and sometime in patients with coronary artery disease, dilated cardiomyopathy, the LV is dilated, and the patient um, patient has this mitral regurgitation. Sometimes there is infective endocarditis can lead to damage to the vascular cusp and chordae. Sometime in patient with myocardial infarction, there is papillary muscles. If it is infarcted or ischemic, you can have mitral regurgitation. In mitral regurgitation, there is a backflow of the blood from the LV to the LA, and there is a dilation of left atrium, pulmonary congestion, and ultimately there is a flooding of the pooling of the fluid inside the lungs, which leads to shortness of breath. And when this is chronic, again there is a right side chambers becomes enlarged, leading to pulmonary hypertension. So mitral regurgitation, one of the causes mitral valve prolapse, and it is one of the very common cause in Western society, mitral valve prolapse. And in Pakistan, the causes are Marfan syndrome, degenerative myxomatous changes. They can all lead to mitral regurgitations. So mitral valve prolapse, uh, uh, how you diagnose? There is usually a mid-systolic click in the mildest form, and when there is a regurgitation, there definitely you have got a systolic murmur, and in severe form there is severe pansystolic murmur. What are the clinical manifestations of mitral regurgitation? Most important is the exertional shortness of breath, which is due to pulmonary congestion. The lungs becomes flooded with fluid, and they also give due to shortness of breath, orthopnea. And due to decreased output, there is fatigue and weakness. Palpitations can occur due to atrial fibrillations, and edema and ascites when there is a right-sided heart failure. Signs: you can have atrial fibrillation. There is a most important is the apical pansystolic murmur, which may or may not be associated with the thrill, occurs at the apex with the radiation towards the axilla. Signs of pulmonary venous congestions like crepitations, pulmonary edema, and effusions are also seen. Signs of pulmonary hypertension and right heart failure. On ECG, in left atrial hypertrophy as well as left ventricular hypertrophy is also seen on ECG. In chest X-ray, you can have pulmonary venous congestions, but the diagnostic, to confirm the diagnosis, again you have to do a transthoracic echo, where you will see the dilated LV, and on Dopplers, you can deduct and quantify regurgitations. This is just for your knowledge, because all these things will be done when you will come to our department and we will see the echo. Sometime when the echo cannot diagnose, we have to do the cardiac catheterization. Medically, again, you have to give diuretics, pills which can increase the fluid in the urine and decrease the shortness of breath. If atrial fibrillation is present, you have to control the heart rate with digoxins, and you have to give anticoagulant. Sometime ultimately, if the patient is very symptomatic, you have to replace the valves. That is known as mitral valve replacement or mitral valve repair. Thank you. Any questions you want to ask? Hello?
जी हेलो।
Hello? जी.
जी जी।
So, any questions? प्लीज शेयर प्रेजेंटेशन हेयर। प्रेजेंटेशन तो हमने शेयर की हुई थी ना। एनी क्वेश्चंस? हेलो? हेलो? हेलो?
जी जी हेलो।
जी, मैं इनसे पूछ रहा था कि कोई क्वेश्चंस तो नहीं है, मगर ये मेरे ख्याल है दो ही आए हैं
क्वेश्चंस नहीं
क्वेश्चंस।
आए अभी तक इधर।
ये थैंक यू सर आ रहा
जी
है। हाँ, ये प्रेजेंटेशंस दोबारा मांग रहे हैं इनको, फिर या तो वो कर दीजिएगा।
बिल्कुल सर, ये जो कोऑर्डिनेटर है उनसे कह के रीशेड्यूल करवा लें।
क्यों?
सॉरी सर, आपकी आवाज समझा नहीं मैं, क्या कह रहे हैं आप?
नहीं, मैं कह रहा हूँ कि इस वो चाह रहे हैं कि ये प्रेजेंटेशन उनको सेंड कर दी जाए।
बिल्कुल सर, प्रेजेंटेशन का ये करें कि क्लास के जो सी आ रहे हैं उनको आप दे दें और वो
हाँ,
जो कर
वो
देंगे।
फिर शेयर शेयर कर दें। हाँ,
बिल्कुल बिल्कुल।
ठीक ठीक ठीक, चलें, थैंक यू।
ठीक है
फिर
सर,
इसको
ओके सर,
स्टॉप करते हैं हम। ठीक है, थैंक
ओके।
यू।